Hello and welcome back to the AHF podcast. I'm your host, Joe Schwab. Most residents coming out of training today will have had some exposure to anterior approach total hip arthroplasty. Adult reconstruction fellows in the United States will often consider surgical approach as a key distinguishing factor when choosing fellowships. All of this is to say our young orthopedic learners are coming into practice with greater and greater levels of experience in anterior total hips. But what do you do if you're already an established surgeon and you're looking to add anterior approach as part of your practice? Has the opportunity already passed you by? How much time do you need to take from your practice to get comfortable with the approach? And how steep is the learning curve? Well, my guests today have done just that, and they're here to answer those questions for you. Joining me today is Alex Sah of Sah Orthopedic Associates at the Institute for Joint Restoration in Fremont, California, and Dr. Michael Blankstein at the University of Vermont Medical Center in Burlington, Vermont. Both Mike and Alex started their practices doing posterior approach and have gone through the process of adopting anterior approach. Let's listen in on the conversation. Mike, Alex, thanks for joining me.
Thank you, Joe.
Thank you for having us.
When you were considering this process of changing your practice, moving from posterior approach and adding anterior approach, what factors were you considering? Was it economics? Was it intellectual factors? Or simply outcomes? Or maybe something completely different? Alex, let's start with you.
Those are all great considerations, Joe, in making that transition from a posterior approach or different approach to anterior hip surgery. When I was in practice about 8 years ago, I was doing exclusively mini posterior approach. People were doing very well. People were going home same day already, and we're doing them at the ASC also. So for us, it seemed like we couldn't be doing it any better. We were very happy with it. And I was looking at some of the other results being published. As we know, early literature on anterior hip replacement is very different than current literature on anterior hip replacement. So combination of factors we can talk about later, but probably because there were surgeons who should not have been doing anterior approach who were doing it. I think people were not learning appropriately and complications were much higher. Things being reported in the literature, I think, were not really showing how well-trained anterior hip surgeons were performing. So that kind of literature, that kind of negative backlash of the early growth of anterior hip approach made me hesitant to adopt it. And again, things were going very well for me with my standard mini posterior approach. So at least for me, it wasn't about economics or more business or promotion or trying to be different or setting myself apart from others, which are perfectly reasonable ways and reasons for other people to adopt something new. But for me, it was simply a question that arose, which is, could I be better? I was very happy with what I was doing already, but the question was simply, was there a way where I could be even better? And if it wasn't for Joel Matta and Charlie DeCook, who approached me and were willing to teach me and ask me to be involved, I don't know if I would have converted. So as you know, I was involved with the Anterior Foundation early on, and Charlie and Joel asked me to give a talk on why I would even consider anterior approach, having never done any and being the only posterior hip surgeon in the room at the Anterior Foundation. Talk about being a black sheep. So I felt very out of place. But that meeting, as we all have grown to love, is just such an amazing environment to learn from others and ask questions that I quickly started to do them myself. And it was really because of that question, could I be better? And Charlie was kind enough to come out and do the first 3 cases with me. And after those 3 cases, I never looked back.
Michael, how about you?
Amazing. Very similar story. A few slight differences. This is actually one of my favorite questions that people ask me because I've truly changed my practice. So when I graduated in Canada, I finished my fellowship. I was very happy with my training, moved to Vermont in 2012. And one of my partners, Nathan Elms, who I hope listens to this, started doing the anterior approach at the time. We're essentially the same cohort. And when I graduated in Canada, I think there was literally one anterior approach surgeon in the entire country. So it wasn't even something I thought about. And I was so happy with the way things were going. And I actually scrubbed in with my partner in my first year in practice. And I literally remember thinking, this is crazy. There's no way I'm ever going to do this. I was disoriented. I didn't know what's right, left, posterior, anterior. The releases looked so challenging. And And as a matter of fact, as you know, I love academia and research and science, and I could quote all the papers in the world that said bad things about the anterior approach. The wound problems, the blood loss, the periprosthetic fractures, the stem loosening, like you name it, the numbness and the learning curve. And it's just like, there's no way I was going to do it. Things started changing when I met you, Dr. Schwab, when we did the Hip Society Traveling Fellowship to the UK. And we went to many meetings where you literally were the only one who did the anterior approach. So I felt very comfortable. I was like, okay, what? The guys in Canada don't do it. The guys in the UK don't do this. So I'm good. And I kept with my hard-minded approach of, hey, I'm sticking to the posterior approach. And then somebody once said to me something interesting, which was, how about you listen to your patients? What do they want? Why are they asking you for the anterior approach? And I'll tell you this one humbling experience that I had that really changed my practice. It was one day we were sitting in a meeting and they were just talking about the wait times and access to care in Vermont. And they said, well, the wait list to see Dr. Blankstein, this is 5 years in. I'm already doing a good job. I really don't have dislocations. Things are fine. The wait list to see Dr. Blankstein is like, oh, you can see him next week. The wait list to see Dr. Nelms is like 5 months. I was like, okay. I'd rather learn a new approach and do what people want than speak badly about it for the rest of my career. Like, I'm a hip surgeon. I love doing hip surgery. Why not just learn a new approach? And this is really what I want to do here and really is compliment the AHF and all the teachers that Alex, you just mentioned. The Cook, Schwab, of course, the modern day Charlie, Joe Mata. I said, I'm going to go to their courses. And the way the courses were taught was just so responsible, right? So as hip surgeons, we've all seen bad things happen, metal, hip resurface, all these stories about us not adopting something new responsibly. And this was done responsibly. There were courses, tips, booklets, videos, visitations, and I did every single course. And I met so many people like you guys. And I decided I'm gonna embark upon it. And just like Joe, just like Alex said, like I haven't moved back. I haven't gone back. It's been really rewarding.
So your partner was able to scrub in with you on your first few cases, kind of help you through that process. Alex, what was that like for you?
So that was a challenge, Joe, because I was the only surgeon in my institution to be doing anterior approach. So we were starting completely from scratch. So that means our nurses, our techs, our reps, right? We just got our first Honda table. All of this was brand new. So that definitely was a challenge because suddenly now, as Michael said, as a surgeon, things are upside down and backwards. You're looking at the hip from a completely different perspective. You're trying to learn it yourself, but at the same time, in the corner of your eye, you're trying to keep an eye on the person managing the table, the implant rep, the person running the C-arm. There's a lot more coordination. And that's something that is truly different with that approach because it's really a coordination of all the team members. So being the first person in my hospital to do it was a challenge. But when you asked about learning curve, I would say the learning curve, it depends on how you define it. Learning curve, you learn a little bit for many, many cases. I think we all say we always learn when we do another anterior approach because we're always trying to find ways to be better. So that learning goes on for quite a long time. But when you're talking about a learning curve in terms of avoiding complications or problems, with modern day training, and Joe's been involved with it a lot and is a great teacher of it, you can really avoid those complications early. So I think the learning curve actually can be very short with modern training.
That actually raises a question. So I think the way that both Alex and Mike, that you've described your approach to the educational process is a very positive one. What were the biggest challenges or the biggest difficulties that you encountered during that educational phase or during that growth phase of anterior approach in your practice?
I think the thing that was very important for me was not to have these early complications, right? I did, because everyone knows, okay, so this is a posterior approach surgeon, and now he's going to do the anterior approach. And if it doesn't go well, then everyone's going to know about it. And I actually heard some stories about surgeons trying and things not going bad and reverting back to the posterior approach. So I think this is, again, one of the things that I learned from you guys, which is let's choose your first patients appropriately. Just in itself, just know when to do it, how to do it, have the support personnel. Hey, also don't change. Another thing that I learned was very interesting is, again, don't change the implants. You have to, so for example, if you wanted to use an anterior friendly stem, then you have to get comfortable with that stem while doing the posterior approach. Um, and then it's literally learning from every single step, every single. I'll give you another example. Was one of the biggest challenges I had in the beginning was cutting the neck to the front. And once it was too high, once it was too low, and I brought in X-ray, I'm like, okay, that's standardized. Boom. And it's like that. Just like you said, a whole bunch of little steps,
Early in the learning curve for me, Joe, it really wasn't a challenge to learn the technique or go to a cadaver course, or there was so much opportunity on the web. There are videos. I mean, modern day training again is very, very different than early training when I think those learning curves were being published and they would be more challenging. Modern day training has VR, it has web, it has, all kinds of materials on the internet where you can watch videos. So really the only challenge when first adopting was really going somewhere to go to a course. It was really more of an inconvenience than a hurdle because you had to take time out of your practice. You had to go to a course and learn it, but it is well worth it because the ability to work in a cadaver lab, go to one of these educational courses that are now everywhere from various implant vendors is extremely helpful. And I think one of the best things for me, at least, was having that reverse visitation. Having someone with you when you do your first, I think probably sped the learning curve up by 10, 20 cases, honestly.
This episode of the AHF podcast is brought to you by Mizuho OSI. The HANA table has been transformative to my practice in so many ways. Once you realize what can be done with a solution like that, it's hard to operate without it. The HANA distraction pad is a simple advancement to patient positioning, but a great testament to how innovation impacts the orthopedic space. It's one small change that adds significant outcomes. The soft, disposable, friction-based pad enables you to remove the perineal post, allowing for post-free hip procedures on the HANA table. It contributes to advanced, post-free techniques for hip preservation, ergonomic and easy patient transfer, while keeping the full functionality of the HANA table in the supine position. The HANA distraction pad is the only validated solution for post-free hip distraction on the HANA table. More options for your HANA and continued outstanding patient results. Learn more about how the HANA distraction pad is transforming orthopedic surgery by visiting Mizuho OSI at this year's Anterior Hip Foundation meeting. And now, back to our podcast.
So, looking back on your educational journey to sort of adopting an anterior approach, what would you have done differently?
That's a good question. If anything I would have done differently, Joe, is I probably would have done it sooner in my career. I probably waited longer than I needed to. And the reason that prompted me, at least, was learning from people I trusted. And I think that's like anything else that we do as surgeons. We don't adapt or adopt to new technologies until we learn from someone we know who does it. And that's what really makes the Anterior Hip Foundation unique, the faculty and the people who are members, because they're all willing to teach. It is amazing. You can ask anyone a question anytime. They're willing to help. They know everyone has questions and been through that journey. I think the support system is really what sets it apart.
How about you, Michael? What would you have done differently?
I must say, I really have no regrets. I'm happy. By the time I done it, I was, I've really mastered the posterior approach, which is nice. We actually now have the opposite problem that so many people are so comfortable only with the anterior approach that they lost their posterior approach skills. So I've kind of like mastered that. And then, you know what I tell my residents? I go, aren't we so lucky that we get to do the surgery after people like Joe Mata have already figured everything out for us? But had I tried it earlier, I probably would have maybe given up on it. But by the time that I tried, we had, again, everything, all the broaches figured out, all the x-rays figured out. the stems, the implant. It was just like all so well laid out. It was actually really fun. I think that I chose the right time to join the party.
For both of you, you mentioned different types of educational opportunities between industry courses and academy style courses, surgeon visitation, and online videos. What was your preferred way to learn then? And do you think that would be the same way that you would learn now? Or with your experience, is there a different sort of learning style that you would gravitate towards?
Great question, Joe. I think, when COVID came and we thought everything was going to move onto the internet and be web-based, some things have, but some things have not. So I was sort of surprised that not everything's gone that route. Really, what I've learned is you cannot get away from in-person training. There's really nothing better than cadaver training, being with your peers. I think learning from obviously experts in the field has huge value. I think learning from people is also incredibly helpful, because then you have a relationship and you can ask them questions later. You can talk to them when you do your first cases. And I think the modern technologies, such as cameras that can let you watch live surgery or have video recordings that are so prevalent now, really help, because you're going to go to a cadaver course. You might not do your first case for 3 to 4 weeks later. So to have that refresher, to have something available to review, I think makes it a lot easier doing that first case.
Yeah, I agree. I think again, obviously we have more great videos now and great everything now, but the mentorship model here is, I think it's still the key. If you are desiring to transition mid-career, you need to really have some support around you. So just like I've flown in to see multiple surgeons before I did my first one, and I asked somebody to be in the OR with me for that first one. I know, Joe, you guys did your first like 50 together, you and your partner, something like that.
That's correct.
Yeah, so I think that's a big one, because what you don't want to do is find yourself in a situation where 1 second I can't expose that femur, or I had a little crack in the calcar and I don't know how to put a cable on through the front. So definitely be ready to handle that.
Just going to say, Joe, there's no reason to reinvent the wheel when you're starting, right? There are plenty of people willing to help. So take advantage of those who want to help you get through it.
Have there been any surprising moments for you in this journey, or since you started adopting anterior approach as sort of the primary approach in your practice?
I think the surprise for me was that I literally never went back to posterior approach after doing those anterior hip replacements. The benefits of it were remarkable. So when you hear about them being as great as they are, you wonder if it's really just being over popularized or being exaggerated. But again, my mini posterior approaches were doing very, very well, and I was very happy with it. But the benefits I found from anterior approach, having patients supine, having the ability to use C-arm, having the ability to restore leg length offset and have quicker recovery, all these things that are said, really you would see in patients in the recovery. So that's really what surprised me, is that I really didn't have any hesitation to just move 100% forward with that approach.
Yeah, same again, same benefits. One of my earliest experiences was actually working with the therapists, and they're like, thank God you don't have these precautions anymore. I'm like, wow, I didn't realize my precautions were such a big deal. But to be able to tell patients, hey, do whatever you want within reason, just avoid extreme legs of motion, a range of motion, and that's it. And that was cool, because in the beginning, with posterior approach, even though we have data showing you probably don't need precautions, most of us still like some gentle precautions, and to be able to just let go of that altogether I think it means a lot to the patients. But again, I want to highlight one of the things that is really important here, in my opinion. So again, if you look at the science behind anterior versus posterior approach, the differences are very small still till today, right? We're talking about if patients do well at 3 months, they're probably going to do well with both approaches. If you have a surgeon who's able to do a good job, meaning, again, restore the length offset, center of rotation of the hip. If somebody does a good job, you can do it with both approaches, 100%. So the question is, does it make a difference what happens in the first few weeks? Well, if you're a good surgeon, you can do things the same. Well, those few weeks do make a difference to people. So if people ask you and they say, hey, I want to be as comfortable as I can the first day and feel as natural as I can the first day. And I can provide you that. Why are we not respecting that as a community? And I think that's what's happened over the years. We're like, well, we're taking an operation that's so successful already. Can we make it any better? Well, I guess we can by just getting rid of some of the initial pain and discomfort and making the recovery easier. And also knowing that we're, especially with using X-ray, which is one of my favorite things about the anterior approach, is the fact that there's no post-op surprises, right? Like before you're done, you know 100% that the implants are exactly where you want them to be, which is something that I appreciate because with the posterior approach, even though I did such a good job, once in a while, I would have that cup that I wish was a little bit more anteverted or things like that, you know?
Join me next week for part 2 of my conversation with Dr. Alex Sah and Dr. Michael Blankstein. Thank you for listening to this episode of the AHF podcast. Remember to like and subscribe so we can reach a wider audience. If you have an idea for a topic, leave it in the comments. Remember, you can find us in audio podcast form in your favorite podcast app, as well as in video form on YouTube/@Anterior Hip Foundation, all one word. New episodes of the AHF podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips happy and healthy.